Welcome to the MDedge Psychcast. I'm Dr. Lorenzo Norris, and I serve as the editor-in-chief of MDedge Psychiatry.
In this edition of the MDedge Psychcast, Dr. Norris sits down with Dr. Igor Galynker. Dr. Galynker is a professor at the Mount Sinai School of Medicine and the director of the Mount Sinai Suicide Research Lab. Their topic today, how suicidality in patients impacts the emotional responses in the physicians who treat them. Here now, Dr. Lorenzo Norris.
As we're all aware, increasingly in the field of psychiatry, the number of patients that we are actively working with who have serious mental health conditions, who are actively dealing with suicide, has continued to increase. How we actually work with these patients in a way to identify our own responses that would help us identify and treat those who are dealing with suicidality is a chief area of focus of Dr. Galynker's research. Dr. Galynker, please, can you tell us a little bit about what you've learned so far in your work?
My work actually on suicide research started about 10 years ago when I realized that there was actually no way to predict who is going to attempt suicide in the imminent future. Our risk factors identify people who are at risk for suicide lifetime, and the two main factors are mental illness and previous suicide attempts. Each of those factors increase suicide risk lifetime 30-fold. But everybody who we deal with in psychiatry, particularly inpatient units and emergency rooms, has a mental illness and very often attempted suicide. And there was no way to identify or even conceptualize how to distinguish those who would attempt suicide in the near future. And the goal of our research was twofold. One was to identify a syndrome, if such a syndrome exists, of acute suicidal crisis, acute suicidal state that is specifically associated with imminent suicide risk. And the second was to assess how clinicians' reaction to working with people who are manifesting this syndrome and are at acute imminent risk, how their emotional response to those patients may be used both therapeutically and diagnostically.
So, Dr. Galynker, I find it fascinating that you're working on this in many ways, and most of the psychiatrists in this audience or mental health professionals listening to this can relate to it. A common problem that we encounter when we're working with our patients is we can identify chronic risk factors, but as you so eloquently pointed out, they're of limited utility in predicting imminent risk. And one of the biggest challenges from a very practical standpoint, I know that when I've been in the office, is this person, how at risk are they? Do I need to hospitalize? Do they need to be involuntarily hospitalized? All of which have extreme consequences if you get the decision wrong. And you can be, I have felt the weight of that pressure in trying to predict it, but your work in terms of trying to figure out, does this acute suicidal syndrome, if you will, of imminent risk exist? I find it fascinating.
Our research and that of others shows that it does exist. We have identified the syndrome, I would say about 6-7 years ago, and we replicated our findings 4 times in different patient populations. And we also have designed DSM criteria for, proposed DSM criteria for the suicide crisis syndrome and tested the predictive validity of the DSM criteria. There are also other people in the field who are working on similar issues, and specifically Thomas Joyner has described the related syndrome, and we're working together on making it more known and also to include this assessment in everyday clinicians' work. So the suicide crisis syndrome is a cognitive affective state that is associated in our research with about 10 to 15-fold increase of suicide attempt risk of suicide attempt within a month, okay, after you see somebody. And the reason we chose a month, it's your average time duration between 2 psychopharmacology appointments, and it's also time of that you can reasonably research. And it has two components to it. One component is the acute state of entrapment, which is inability to escape an unbearable life situation when all routes to escape are blocked, and death appears the only option. And that's criterion A. And criterion B, there are 4 of them, and they're actually quite elaborate, but each of the 4 needs to be present, at least one symptom of the 4. And that's affective discontrol, loss of cognitive control, agitation and hyperarousal, and social withdrawal. Please note, remarkably, and it's critically also, the suicidal ideation is not part of the syndrome.
The suicidal ideation is not part of the syndrome.
Is not part of the syndrome.
Let me actually just say that again. That is, I find that very interesting. Suicidal ideation is not part of the syndrome. Please elaborate on that, because that's counterintuitive to what I would dare say many people through the years have been trained to think. Basic, if you will, how we talk about suicide. One of the first questions we ask about is suicidal ideation.
Well, that's exactly the problem for a number of reasons. There is a paper actually there is more than one paper, specifically one from Austria from several years ago, that shows that suicidal ideation on average, the duration of suicidal ideation prior to attempt could be 15 minutes. And that means that when somebody has suicidal ideation, it may be way too late. There's also a lot of research to intervene. There's also a lot of research that indicates that some people who die or attempt suicide never have explicit suicidal ideation for reasons that they may not experience it, they may deny it, or in a self-report that we rely on, people who are determined to die hide it. And they hide it very well. In fact, on multiple occasions and multiple papers, people who would go on to die by suicide, in their last communication with a clinician within 24 hours before their death, denied suicidal ideation. So suicidal ideation is an unreliable predictor for 2 reasons. One is that patients hide it, and 2, they may not be aware of it yet. On the other hand, suicide crisis syndrome, which is a mental state that would lead to suicidal behavior, is there and is identifiable, and people actually report it and could be a lot more cooperative in describing it to you, and it's also quite complicated.
Okay. What I think about, I find that fascinating because, again, I think about the legions of clinicians who've been trained and focused on the idea of suicidal ideation. And yes, we all, to an extent, knew the limits of the concept, but what you're saying is that it is inherently, just based off of the evidence of the research, unreliable. This may not be the correct way of thinking about it, but one thing that popped in my mind as you were talking was sometimes patients that we would treat with hypertension. Many times a patient can go around with a very elevated blood pressure and can be completely and totally asymptomatic and have no idea that their blood pressure is risen. And when you're talking about suicidality, this particularly the acute crisis suicide syndrome and the unreliability perhaps of suicidal ideation, are patients, just to quote what you just said, one, they frequently may not know it. And the second point, which I think is huge, is they may be hiding it. So please, yes, fascinating.
It's a good analogy. Another analogy would be along the same lines that you've been talking, actually, is something like nausea in posterior wall infarct.
Okay. Mm-hmm.
So people know that something is uncomfortable, they don't feel well, they're very aware that something is not right. They don't know what it is, and they don't know how dangerous it is. Mm-hmm. And so a lot of people who are in a situation of entrapment in life and have a horrible personal defeat, and by the way, typical situations of entrapment include humiliating professional defeat, mm-hmm. Romantic rejection, mm-hmm. Or untreatable medical illness. Mm-hmm. Okay, and painful medical illness. Mm-hmm. So they're aware things are wrong, but what they don't know is how dangerous it is and how the close they may be to suicide. Some may not know, some may not know, others do know and will not tell you.
Okay. the night with criteria A of the acute crisis, the suicide crisis syndrome, talking about entrapment. My experience has been many of the things that you just identified, patients are more willing to talk about that, those specific issues, or feeling trapped or feeling obstacles. And I think that opens up a dialogue. And again, I find it very intriguing that the patient themselves may or may not fully be aware of the state that they're in. But I think if a number of clinicians start to think about this or reflect, that's probably more common than we give it credit for. And that it is probably more common if we listen to our own emotions or thoughts about it. And I know that in part of your work, you have looked at a clinician's emotional response and their reactions, particularly around the suicide crisis syndrome. What are some things that you've discovered about that?
Well, it's first of all, it's not an easy subject to talk about. Okay, let's start with that. Because current clinician training includes actually not a training really to suppress your emotions, but a training to be professional regardless of what emotions are. And so that actually does not encourage you feeling things. It actually encourages you to suppress what you feel. And in the context of our discussion, that would mean suppress your response. Okay, that could be diagnostic that somebody in the office with you is actually maybe in danger. So having said that, clinicians' emotional responses to suicidal patients are very complicated, and they include a lot of actually negative emotions, which such as distress, fear, anxiety, frustration. That's on the negative side. And some positive emotions would be a feeling of empathy and willingness that you can save the person, and understanding and desire to do so. So that's a very, very complicated cocktail of emotions that needs to be sorted out. But it's very, very intense. And first of all, in our first analysis, when we did that, and we compared clinicians' responses in retrospective study to their patients before their death by suicide, and before their natural death, and before suicide attempts in a blind fashion. And we discovered that actually there were emotions that identified, that distinguish people who would go on to die by suicide and people who would go on to die by natural death. And then we replicated the study prospectively 3 times. And it's very complicated, and this will be part of the symposium on Sunday at 1 p.m. Today. But there are 3 emotions which are diagnostic.
All right.
Okay. And can be identified. One is just plain distress. The sense of distress. Distress to the extent that it gives you chills.
Okay.
The second one is a paradoxical combination of distress and hope. Because if you're hopeful, you shouldn't really be stressed. Okay. And it's almost like an emotional over-involvement type of response. And there is a label for it, anxious, let me think for a minute. I think let's call it anxious over-involvement. Okay. And the other one is a combination of hopelessness and resignation and lack of distress. Okay. And that's a desire on part of clinician to dissociate yourself because the patient is just hopeless. And we call it collusion avoidance. So each of these 3 emotions, when identified, is associated with a heightened risk for imminent suicidal behavior.
It's when you laid out those 3 emotions, I immediately went back to kind of my experiences in clinical practice. And when you're talking the first one, the distress or the chills, I can absolutely relate to that. And I think when I feel that feeling, it's interesting that you said chills, because I do think of, if you will, the somatic element of it. You actually literally feel as though something is wrong, and you can feel it in your body. And one of the challenges at times is instructing our residents, because I teach residents, how to recognize that. And that when you get that chill, what you do with it. The other one, the mixture of distress and hope, I find very interesting because I've also had that, particularly in patients that I've had that are doing well, and then they suffer a setback. And they might be reporting like, doc, it's okay, it's okay. And then something in the back of your mind is like, wait, this feels like it's not okay.
Right.
All right. And probably, I think one of the more concerning ones, well, they're all concerning, this combination of hopelessness and resignation. And I think that would take a great deal of introspection on the clinician's part, because that you have to come to terms with something that you may not be willing to accept about how you're viewing this situation. You may not be willing to accept that you were resigned to this patient is going to die and there's nothing that you can do or that you don't have hope. You may not yourself be willing to get into contact with that emotion or that feeling. But this idea of a clinician and their emotional responses, I should say, in many ways we've been taught this, but it's always counterbalanced with that ability, if you will, to be professionally and to keep your boundaries. And a colleague of mine, Dr. Frank, I'll never forget this, when I was dealing with a patient who attempted. And one time she told me, she said, Lorenzo, when this happens, it's a feeling, a sadness that you won't miss. It took me, I would say, years to realize that she wasn't just talking about the patient, she was talking about myself. And that's the part that I feel so with these emotional responses that is so, as you said, very difficult to teach. One question that I had, just I guess I couldn't help but think about it, with the speed at which we see patients, how much time does it take for a physician to maybe reflect on this emotional response and incorporate it into potentially like their practice or their treatment?
Excellent question. Before I go there, to comment on resignation, the kind of word to cue you in, that you're in that state and have that emotional response would be anybody would want to kill himself in that person's shoes.
Oh, okay.
Okay, if you have that feeling, this is an indicator that you're having this emotional response and the patient is at risk. Now, our work obviously is ultimately not only diagnostic, but we want to design treatments to prevent suicide. Interestingly, it's very hard to establish the effectiveness of this treatment because you prevent something that didn't happen. You don't know it would or would not have happened if you didn't do anything, except the person would tell you. So what we created is a particular approach to assessing suicidal crisis and clinicians' emotions. It's a scale, but it's also an approach. It's called Modular Assessment of Risk of Imminent Suicide, otherwise known as MARIS. And it's a very short scale, it takes 2 minutes. And it has 2 components. It has a patient component, the patient reports on their mental state, and there's a clinician component, where clinician actually records risk and also reports on their mental state. And then if you assess this together, this scale has a higher and actually much higher predictive validity than suicide crisis syndrome alone, which is on the patient side.
Okay.
And the odds ratio of predicting of suicidal behavior within 24 hours on the state combined, include when there's DSM criteria involved, is close to 25 within a month, which means that you're going to identify 60% of people, if you could help them, who would go on to attempt suicide within a month. And with the suicide crisis alone, without clinicians' emotional responses, it's 40%. Still nothing to complain about. 40% life saves out of 44,000 in the United States. It's quite a few lives, but 60% is when you take into account the emotional responses. And MARIS is also an approach to interview the patient. Okay, in a particular way, where you start with asking them about the syndrome. Okay, then assess your emotional response. And your question about suicidal ideation is actually a footnote, because you must ask it, okay, but your opinion is already formed. And the patient is actually, chances of patient hiding of their suicidal intent are much lower because you already did the interview when you asked them. So it's actually in my recently published book, if I may say so, it's called The Suicidal Crisis. It came out last fall with Oxford University Press, And it has, coming back to your question,
Yes.
several what's called Maris interviews.
All right.
Okay, and there's a full Maris interview that may take you 45 minutes if you have time. There is abbreviated Maris interview that you would use in the emergency room.
Mm-hmm.
And there is a super abbreviated Maris interview, which is 2 questions.
Okay.
Okay, that actually give you a lot
Mm-hmm.
if you don't have time for anything. And here are the questions.
Thank you for sharing with me.
And it's criteria A and criteria B. Okay, so criteria A is, do you feel do you feel that you're trapped in a situation that you cannot get out of? Okay, and there's no good options for you. That's criterion A question. Criterion B question is the following. When you think about that, okay, about your life, that you ended up, that there's no future that you can see for yourself, can you stop your thoughts? Or these thoughts take control of you?
Mm-hmm.
This is criterion B. One of them, but that's a critical one. And if the answer to both questions is yes, okay, regardless of the person saying whether they are or are not planning or have suicidal thoughts, they're in danger.
All right. That is a common challenge, and you already answered it in terms of how do we incorporate a structured, if you will, nuanced approach or interview to the suicidal patient. Some of the things that you've said make me think about one of the challenges in teaching, from my standpoint, in terms of teaching residents, is the idea that if you wish to explore suicidality, you actually have to focus on it. You actually have to talk about it. You can't have are you suicidal question, which is almost essentially meaningless. I love those 2 questions in terms of the entrapment, all right, for the criteria A. The other reason that I really like it is because I can keep on asking it. If I wanted to, even though you said it was designed for just two questions, which I think is good, I can actually keep coming back to that in different, if you will, parts of the interview in different ways, and just keep on asking it. Particularly, I guess what I would maybe think about is what you said about one's own emotional response. If I detected myself being distressed, I might ask that like 3 or 4 times throughout the period of, let's say, a typical psychiatric interview, let's say 30 minutes, a standard one in terms of what we were all used to be trained in terms of oral boards. So just those questions that you outlined, I think they could be asked at the start, the middle, and I as well as at the end or the tail end, depending on if I'm hearing you correctly, based off if I am aware or aware or sensitive enough to know my own level of distress regarding the patient. Now, I will say, I think it would be a challenge for a lot of folks to know their own emotional level or where they are at or their own state when you're in a very, 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 very busy clinic setting. But I love the different forms of the interviews.
Thank you. When I said 2 questions, that was 1 minute interaction.
Yeah.
Usually we have more than 1 minute.
Oh, yeah, absolutely.
And there's several versions of Maris. In Maris interview, it's called in the book. And the way that would work, and there's also, by the way, the book is a manual, a teaching manual. Okay, so you can use to teach how to assess people. In fact, we have given several courses at Mount Sinai, and I think we're going to adopt this approach already to a large degree and adopt it informally in our emergency rooms. But the way it would work is that you have your Maris interview, and again, it's described in the book, and then there are key questions that you ask yourself to help you identify your emotional response and your behavior. And you can actually, after you ask yourself these key questions, okay, and say it's yes, no, yes, no, yes, no, it will tell you where you are emotionally. And then you correct the risk that you assessed without your emotional input, okay, and identify the real risk, and then you act.
Right. Well, Dr. Galynker, you've really informed and educated us about, if you will, the suicide crisis syndrome, different ways to think about suicide, which in many ways would be counterintuitive. A final question that I always like to ask folks is, throughout your work in the field of suicidality, throughout your exploration of the suicide crisis syndrome, what's been the one thing, if you would, that kind of surprised you, that kind of like like, whoa, I wasn't expecting that. That is really interesting, or something that maybe you don't normally teach or something like that, but it just struck you.
Probably the fact of the emotional response that it turned out to work. Okay, because when I had the thought, and everybody said, well, you have this gut feeling, and the question was, well, I'm actually going to look into this.
Yeah.
I'm going to look into this and define it. And when we did our first study, and a lot of people thought that's pretty out there, and we got a really strong positive result. That was the biggest surprise.
Well, I thank you for speaking with us, and we have, throughout in the field of suicidality, I know that many are coming up with a number of different techniques. I mean, people have tried to look at functional MRI, they've tried to look at various things. And in certain ways, it's like coming back full circle with the science, and that if you learn to listen to your gut, you can help your patients. If you learn to listen to your own emotional response, and you have a systematic approach, and you understand that suicidal ideation in and of itself is unreliable, and that you and the patient working collaboratively, when you're focused on ideas of entrapment and factors that can lead to the suicide crisis syndrome, we can better serve our patients. Dr. Galynker, I want to thank you so very much for taking time out with us.
Thank you for having me.
And that's it for this episode of the MDedge Psychcast. You can listen to previous episodes as well as a new episode every Wednesday on iTunes and at mdedge.com. For MDedge, I'm Nick Andrews.